Dr. Anand Rajendran, please.
Yeah, thank you. At the outset, I'd like to thank Dr. Abnindra for putting up this wonderful IC, and I think it adds great value to this conference. So it's my pleasure to talk to you about macular as well as Widefield OCTA in diabetic retinopathy. So the role of OCTA in DR, it's demonstrated, primarily demonstrates retinal microvascular changes, be it structure or morphological alterations like microaneurysms, tortuous dilatation, irmas, NVs, and collaterals. It also highlights structural loss in the center, showing up capillary non-perfusion, and therefore, as we talked about earlier in discussion, macular ischemia and enlarging FAZs, and in the periphery also, and through structural density metrics such as perifoveal capillary density. This translated clinical value is also showing all these changes from the preclinical diabetic retinopathy stage to the proliferative stage through all these anatomical issues, and also highlighting and giving us an ability to objectively evaluate diabetic macular ischemia. It also is now increasingly helping us correlate diabetic macular edema and anti-VEGF response, and we'll see in a bit how. Also highlights peripheral changes as we are enhancing our ability with Widefield OCTA, correlating retinal capillary non-perfusion and diabetic retinopathy stage, as well as looking at and understanding evolution and regression of IRMAs and NV. So this is how we'll go about. So the matchup, FFA versus OCTA, Dr. Lalit's talk just now kind of highlighted all that, but understand that the FAZ on FFA correlates very well to the OCTA superficial vascular plexus FAZ. Okay, so these are very comparable, but understand also that the FAZ on the deep vascular plexus can only be studied on OCTA. You can never see that on the fluorescein angiography. So this is something also to understand. The FAZ in the superficial vascular plexus and the deep vascular plexus may be differently sized. And so it's OCTA is the only one which gives you this capacity to look at that. All right, so looking at OCTA FAZ in clinical DR, early changes and stages. So like I mentioned earlier, preclinical diabetic retinopathy, OCTA is the only one which can really give you early citers, okay? Be it the disruption in the FAZ at the superficial capillary plexus, as you can see, or focal microaneurysms that you can pick up in the DCP, which can correspond to focal capillary non-perfusions in the choriocapillaris. So if you have a diabetic patient who's coming in and you get an OCTA and you pick this up, you can tell the patient that you're probably hurtling more towards a manifest diabetic retinopathy if these changes are there. Now, OCTA FAZ and the diabetic retinopathy changes. Now, Kim et al. Did a very elegant study and just showed us, one of the first to show us, that increasing FAZ dysmorphia and diabetic macular ischemia definitely happens as you progress with the diabetic retinopathy stages. As you can see from the healthy to PDR, that FAZ is continuously increasing. So not just is a manifest retinopathy increasing, but also is there is a slight push towards ischemia. And Alam went forwards and quantitated these OCT analysis and helped computer-aided identification and staging of DR. Now looking at OCTA FAZ and diabetic macular edema and prognosticating of anti-VEGF response. Now Lee did a very nice study with OCTA DME and its association with anti-VEGF response. They looked at 51 poor responders, 32 were good responders, and they found that in the poor responders there was significant damage to the deep capillary plexus, not quite always superficial capillary plexus, and the marker for poor response to anti-VEGF is DCP loss right at the outside, at the baseline, and the corresponding OPL, outer plexiform layer disruption. So I'll just show you a few examples. An example of a good responder where there was lesser distortion of the DCP, more microaneurysms, again we talked about this earlier, is seen on deep capillary plexus than can be appreciated on fluorescein angiography. A poor responder, on the other hand, had a greater distortion of DCPs, and you can see the microaneurysms again being seen better on the DCP in the right mantle than fluorescein angiography. Okay, so this is just some examples from our experience. You can see DME with a good response, good resolution with anti-VEGF treatment. Some as superficial capillary plexus loss, DCP loss also. But you see a case with a poor response, where it was fairly refractory to anti-VEGF initially. SCP loss was there, but you can see that the deep capillary plexus loss at baseline is far more. So if you when you're treating your patients, like I said, if you can get an OCTA done and you find at the start macular edema with a significant deep capillary plexus loss, that should ring alarm bells and tell you that perhaps this patient may not respond very well. Perhaps you may even think of moving straight away with a stronger anti-VEGF. So these are considerations that you can keep in the back of mind. Now, OCTA FAS and diabetic macular ischemia. So this study by Rosen showed that, like in Kim's study, the FAS increases as you go down, as you increase and become more severe with your diabetic retinopathy, but also it is the perifoveal capillary density which is also dropping off. Look at that map on the right panel. That red signature is continuously decreasing. It's becoming more yellow. That means the vessels, not just in the FAS is increasing, but around the FAS also the vessel capillaries are dropping off in intensity. Now, Bradley did a nice study looking at evaluation of diabetic macular ischemia using OCTA, 24 patients. This was the definition of DMI. And they looked at FAS, they looked at FFA versus OCTA, and looked at the three layers that we talked about, SCP, deep capillary plexus, choriocapillaries, and brought out a very nice grading system, very intuitive grading system, which they evaluated for reliability and consistency. So this was what they did. I won't go into all the basic. The FFA and SCP were looked at together. They had these 6 grades: absent, questionable, mild, moderate, severe, ungradable. In the mild versus moderate, it was FAS outline disruption less than half original circumference or more. The DCP, they made it into a 4-quadrant grid. Again, these 5 grades, and mild to moderate and severe FAS outline disruption less than equal to 2 quadrants, or FAS more than 2. And the choriocapillaris lay, again, they did a 4-quadrant. It was a plus or minus, dark defects plus, loss of HR homogeneity, and minus. So just an example from there where they found FFA here, for example, DMI. Okay, less than half FAS, and DMI less than half. So this was just an example where they show here the DCP, there was a 2-quadrant FAS disruption, mild to moderate DMI, choriocapillaris, dark defects with DMI is present. The key findings is degree of DMI was reliably assessed by OCTA SCP, and there was moderate agreement between DMI grading results for OCTA SCP and FA. And most important thing is far more integrator agreement with OCTA than for FFA. Okay, now Widefield OCTA, the enhanced implication for PDR. Anand showed that OCTA FAS dysmorphia and DMI correlated very well with increasing peripheral capillary non-perfusion. And just a few examples to wind up. Widefield fluorescent angiography here, an example, you see retinal thinning there. And like we talked about the different scans, you can see it in the 3x3. But as you go further, you are seeing more and more of the retinal thinning correlating very well to the ischemia in the periphery also. Another example where you find that thickness seen initially in the 3x3, but also very well in the larger maps. And you see the this non-perfusion, and when you go from the superficial flow to the vitreoretinal flow, you see small area of neovascularization also being highlighted here. And when you do the OCTA, Widefield OCTA, you see that corresponds very well to a little tuft popping up above the ILM, which tells you that this is correlating, this is a new vessel, and you can see that here also. So this shows you, also we talked about flow overlay B-scan. You see this high magnification SS OCTA shows an IRMA evolving into a new vessel. You see as that flow overlay becomes more intense and surfaces towards ILM, you will see it popping up, breaking through the ILM. That's when it becomes a new vessel. And this is also showing the evolution of the NV captured, as you can see from baseline. That flow map signature is going up, getting more intense through baseline through 1 month, and then breaking through at 3 months, and you can see a full-blown NV there. So that's also a way. So IRMA can evolve into retinal neovascular lesions, as the Rosenfeld group showed us, can directly evolve. Widefield SS OCTA can early detect, and you can frequently monitor IRMAs and NVs. And in summary, using the same field of view, Widefield swept OCTA was quite similar to ultra-widefield fluorescent angiography, and changes were well seen on Widefield swept OCTA, and or IRMAs, NVs, and areas of retinal neoperfusion can be identified on SS OCTA. So in conclusion, diabetic retinopathy stages, I'll just put everything together. Increased FAS dysmorphia, diabetic macular ischemia can be seen with progression in DR stages. DME grades, there's increased DME severity, FAS area, foveal thickness correspond well with worsening acuity. Anti-VEGF response, DME. Poor response, let me reiterate, the significant damage to DCP, not quite SCP at baseline, and therefore you can use that as a poor marker for poor response. degree of diabetic macular ischemia can be reliably assessed better by OCTA on the superficial capillary plexus, and there is far better intergrader agreement. That is, you have multiple OCTAs, you will have the better agreement than with FFA. Peripheral capillary non-perfusion, the octave has dysmorphia, can correlate to your peripheral capillary non-perfusion also. And in summary, finally, Widefield octa has the potential to replace color fundus imaging and FFA as a potential gold standard later. Thank you.
And thank you, Anand, for your elucidation.